Hello, everyone. A few days ago, I posted a case on the Dental XP forum where I shared a few photographs of a large rehabilitation that we did on a 60-year-old female patient. So today, I'm actually going to do a little video explanation of what we're doing with a voiceover, so we can go through this case. So I can share with you our learning curve and what we did with this. So as you can see, the initial situation is very dramatic. This patient was a heavy smoker and still actually does smoke, regardless of the fact that she's been diagnosed with pulmonary emphysema. And she'd pretty much just given up. And as you can see from the lateral photographs, these bridges were moving. She'd had some dental work done about 30 years ago, and she'd just given up. So quite a dramatic way to start, and she was very self-conscious about her smile, and she wanted to be able to smile properly. So aesthetics were high on her list of priorities. And as you can see here on the initial panoramic X-ray, we have some severe bone loss. We have some periodontitis and some tooth mobility. But the good news was that we actually, the lower canines and the lower premolars were actually quite stable. So from day one, we knew that these teeth were something that we wanted to preserve. Now, the top was pretty much far gone. So our thinking from the early onset was that these teeth needed to come out. So we, of course, did the CBCT study, and we spoke with the patient, several options, and for her, thankfully, and for us, money was no option. She said, just please do the best for me. So I sat down pretty much, and we did a treatment planning here. So we decided to do as much as we could for her. So we were going to take out that lower right molar, so because of it had some mobility, so instantly we were going to plant some implants on the lower arch and rehabilitate that, and full extractions at the top, and simultaneously place implants and rebuild the maxilla. So she accepted the treatment plan, and now patient came in. We'd had an initial impression that went off to the lab to make an immediate temporary removable denture in the morning. So now the patient's fully anesthetized, and we are just doing at the back, because we had good keratinized tissue, we're just doing tissue punch to get the morning started so she could relax. We placed these two implants, 3.5 millimeter diameter implants from Megagen AnyRidge system, and those were placed quite quickly. And I used low rotatory speed, so about maybe 125 rotations per minute with no saline, so I could harvest that autogenous bone. And here we can see the parallel pins with the X-ray just to make sure everything's going well. That's pretty basic stuff. Then we went on to the lower front arch, where we extracted her 4 incisors and cleaned everything up. And here we are using a piezo surgery from the WH system to clean up the bone, make sure everything is nice and clean and ready for the implant placement. So again, we're placing a Megagen AnyRidge implant here immediately into the extraction site of tooth 41 and 31. Excuse me, I'm going to be using European numbers here. And following the new protocol, which is, of course, submerging these anywhere between 1 to 3 millimeters subcrestally, so we can use a platform switching technique to lock those implants into the bone. So now, what you can't see here, but on the left, and here from a top view, we've placed those implants. We've measured the ISQ. The ISQ was well over 70. So according to this manufacturer, I can now immediately load these implants. And what you can see here in this image is now I'm placing some xenograft from Genos from Osteobiol. which I've actually mixed with some PRF that was harvested also at the beginning of the surgery. But what that is an abutment which basically brings my implant to the gum level. So in this case, I think it's about 4 or 5 millimeters in height. And this is the one abutment one time. So this is torqued into place, and we don't touch that anymore. I really, really like this new technique because once that implant's in, it's well buried into the bone and you don't play with it anymore. And here we have an aerial view of our octa abutments, and you can see the positioning of these implants a little bit more lingual to allow for a good buccal bone volume, as we know that is crucial for longevity. And these octa abutments, they also come with the Megagen system, and these are torqued into place. A good torque, I think about 35 newtons, and those will now stay there, hopefully for life. And all of my rehabilitation now is done over these octas. Now, I know a lot of surgeons and prosthodontists, and just to be clear here, I do the surgery and the prosthetics simultaneously myself. So there's no waiting time here, and I'm the one that does this abutment selection at the same time of the surgery. It's pretty standard. It's crucial to have stock. So we do have a lot of these abutments on site. So sometimes I might plan for a 4, but I have to sink my implant a little bit more, and then I have to place a 5 millimeter octa. And why would I sink that implant? To gain a little bit of extra insertion torque and a higher ISQ. So I'm not really worried about how deep my initial implant goes because I have a good selection of octa abutments to bring it always to surface level. Now, here we are packing in that xenograft, nicely packed to fill in all the defects. And we've got some nylon suture. And this is just a bit of fibrin sponge to help the clotting. And I'm instantly now thinking of my provisionals. So I have now screwed in these titanium abutments, these metal abutments here, and I'm now putting in a Teflon because I'm going to put in my temporary abutments. So what I do, and the way I do it, is I put a flowable composite direct over the surgical site, just directly, and I fuse it together, as you can see on the right. I just polymerize that with some light curing. And over that, I have an initial impression in Improgam or an alginate, which I just fill with Bizacryl. I really like this brand, Voco, and I just use their Bizacryl and nanoparticulated 3C, and I just inject it into the alginate mold and put this over these temporary abutments. And as you'll see in a moment, we actually get very close to the initial teeth, and then I will drill through the Bizacryl, screw out the screw it out, polish it, make sure everything is nice and smooth, and then just screw it back into place. It's very easy. It's very, very fast, and I hope to post a case soon on how we do these temporizations. Now, once that's done, what we don't have here, the photographs, is that I also did the implants on the other side. So I finished the bottom first, harvesting the bone from both sites, and now I'm ready to go to the top. So now we're doing some extraction of the top teeth. We pretty much had to extract everything. Actually, today I probably would have done a socket shield technique on these front incisors, and probably some root submergence. And Dr. Maurice Salama and my friend Howie Gluckman, they've got some great cases on this. Dr. Jorge Campos from Vigo in Spain. These guys have a lot of beautiful lectures on how to do socket shield, and you must follow their work. So here we are now cleaning everything out, and we got to work. Now, what this is here on the bottom left is the result of the Smart Dentin grinder, which is made by an Israeli company. And what it does is you have a chemical procedure that on natural, untreated teeth, so basically the tooth has to be sound. There's a chemical process and then like a coffee grinder, which grinds these teeth into these particles, and you use that as a substitute to regenerate. And I'm not going to get into the science behind that, but you might want to look it up. It's pretty cool. I still didn't feel 100% safe, despite the fact that the literature says you can use this around implants, but I was using this just to regenerate large defects in the posterior region. I preferred to put the autologous mixture with xenograft around my implants. Now, this burr that you see in the central image is made by Densa, and what happens is this actually is it goes anti-rotational, and it's a bone condensing burr. This is made by a company in Dawel distribute this, I believe, and my friend Salah, Dr. Salah Houé, he developed this, and I think recently there was a bone condensation, or osteocondensation summit recently in the US, and it really does work. It's a wonderful technology. And so we're actually preparing the bone here. We've cleaned everything with the piezo surgery before. Of course, we're cleaning up any granulous tissue, any excess tissue that we don't want. And on the top left photograph, you see us, we've already placed one implant and we're taking the ISQ measurements. We use a little device called the Mega ISQ to measure, which is Ostel technology, and we have another device called the Mega Torque, which is a little handheld torque device to make sure that these ISQ pins are always torqued in at 10 newtons, so we have a standardized torque measurement. Here we now are using Dr. Joseph Shukran's PRF, and this was just one of the first of many. We harvested quite a bit to help also with the healing. And of course, Dr. Shukran's work is amazing. So to know more about this technology, just follow him and make sure you get to know more about this wonderful technology. So in this photograph, you actually see us on the top left using the Versa Densa burr, osteocondensation burr, to inject bone into the maxilla. So because it's anti-rotational and because of the very specific design of the burr, it's wonderful to do transcrestal sinus lifts and to condense the bone, and it helps to inject the bone up into the socket. It's wonderful. And in this, in the main photograph, you can see us placing this beautiful blue AnyRidge implant. Now, this is a 5.5 or 6 millimeter implant, and that's one of the good things about the system, is because it has a 3 millimeter platform and it goes all the way up to 8. So you can always choose the right implant to get good primary stability. And again, it's important to have stock on site. And here we are now, we've placed our implants. We're now regenerating all of the defects with bone regeneration techniques with the autologous bone mixed with the patient's own plasma. And also doing a little bit of soft tissue regeneration to get some more keratinized tissue around one of those implants, because she had a huge recession. So we took advantage of this huge flap and just got a bit of soft tissue there from the palate, and just doing a bit of regeneration here. So this is the occlusal view after the surgery, and everything's nice, closed, tension-free. And once we did that, we took a panoramic X-ray to make sure everything was in place. So there's no guide. This is freehand. I was actually very proud of this photograph because it pretty much looks like it was a guided surgery. And you can see different size implants, different lengths, different widths. And to know more about the AnyRidge system, you can find out why I'm really enjoying this implant and its applications for immediate post-extraction. And actually, the last implant in the fourth quadrant, that was placed in a post-extractional socket of a molar on the mandible with a lot of regeneration around it. And I didn't know if this implant would actually succeed, but the truth is we had huge success with this implant. So I placed it just hoping that it would work, and the truth is it did. And you can also see on these implants on the bottom left quadrant that they're submerged, and the healing abutments adhere to the platform switching technique. So we like to submerge these implants. Now, after 48 hours, we had a PMMA structure made in our lab using the zirconzan milling structure. So this is milled, and it's screw retained. So this is after 48 hours. What I'd like you to notice is the very, very little swelling that this patient had. The healing is incredible, and I owe that to two things. One, the speed of the surgery, and the second, the PRF, I believe, and of course we also used low-level laser therapy right after the surgery, which actually does help in healing and in the improvement of swelling. So this is a 48-hour photograph, and you can see now my immediate provisional structure on the 4 lower centrals. So this is a 2-month follow-up photograph. We've unscrewed the PMMA, and we're now doing soft tissue modulation. And here you can see everything's nice and closed. We've got some good buccal volume there, and still a bit messy at the back, but it is healing nicely. So we then worked on the PMMA structure, just adding a bit of composite and to help us with this soft tissue modulation. Here's at 3 months, and you can see beautiful papilla there growing. I'm very, very proud of this photograph, and quite happy with the results. And here we have the final situation on the day that we cemented. Truth be told, I'm not entirely happy with the end results. We still need to have a little bit. We had a bit of soft tissue migration on the top right there on that on canine number 13. We're waiting for that to see if it comes down. We're monitoring it, but it's everything is smooth and clean for hygiening, for the hygiene. And of course we have some natural crowns over her natural teeth on the bottom canines and premolars. So not perfect, far from perfect, but that is her own papilla in between her 2 centrals. And again, in all honesty, I actually think the temporary had a nicer design than this final structure. As you can see here on that canine, still not 100% down, but these photographs were taken after 1 month. So we hope to send up some follow-up photographs soon to see if that did migrate. And I will be presenting this case at the XP meeting, hopefully this year, and in a lot of other lectures. So again, not a perfect result, far from perfect, but we try to keep the natural gum in here, and at least we tried to do our best by her, and maybe in the recent future I might actually think about changing this top structure and making a new one. So we're actually considering using this what we're seeing now on the right, on the upper, as a temporary. So this is a zirconzan infrastructure with a stratified Evoclar ceramics over it. But maybe in a year's time we might actually change that for a new one to get some better aesthetics, just because we're fanatics. But she has a natural smile. She's happy with it. This is the final panoramic X-ray. And hopefully we will have stable results with that over time. And all I can say is that we're going to keep you posted with this. So there's the before and after, and the patient's smile. So quite a challenging case, and we have a happy patient. So just a little sneak peek behind the scenes. And of course, thanks always to Dental XP for helping us post these cases and creating these interesting discussions. And I think it's very important that we, just on a finishing note, that Facebook does create a lot of illusions of perfection. This is a paying customer that has a life. She had very few appointments at White Clinic, so she must have come maybe 6 times to 7 times only to do all of this work. So this wasn't 100 times at the clinic, because time is money. We do run a business here, so to achieve sometimes the perfection that is expected, that I see a lot of such perfect work on work, and I'm sure we could have done a lot better here with this patient, given more time. But this is real world dentistry, and this is a real life patient. So the most that I think that we can strive for is just making sure that it's biologically sound, that it's mechanically valid, that it's based on good, sound scientific evidence, and that the literature supports what you do using good materials, good ethics, and we're only human, and the only true perfect smile is the one that God gives us. So thank you very much, and I hope to be posting again real soon.